Our next speaker has fans worldwide. Dustin, oh Dustin. He is SVP of our behavior change practice at MadPow, and he actually brought the wonderment of behavior change to MadPow about 10 years ago now. And we built out quite the practice, as I mentioned in my opening yesterday, where we're blending evidence-based, outcomes-focused approach with creative and innovation process. He's going to be sharing with you how we can kind of unpack what is this behavior change and how do we leverage it and how should we be considering it in the work we do. He has a stack of psychology books, say yay high. So he's a wealth of knowledge. I hope you enjoy his presentation. Please welcome Dustin.
Good morning, everyone. Thanks for having me, and thanks for coming and participating today. As Amy mentioned, I wanted to spend a little time this morning to talk about how we think about behavior change and specific processes that we use when designing for change, particularly when we think about this combination and this overlap of using rigorous behavioral science methods with human-centered design methods to get the best of both worlds, right? To get evidence and rigor along with creative ingenuity and person-centered focus. And I'll talk to you a little bit about how we think about that. At the top level, all of us share a common mission, right? We want to improve the health and well-being of people everywhere using our own unique skills and our perspectives. To do that, it is probably essential to change some kind of behaviors. We think specifically about a network of behaviors, and behaviors being a network of different behaviors within and between people that either combine into positive patterns or conflict, resulting in some unwanted patterns. When we think about health and health behavior change, we think specifically about all the different behaviors people can do to prevent disease. We think about behaviors that contribute to self-management of long-term conditions. We think about behaviors around care-seeking and adherence to treatment, and we think about behaviors that involve the delivery of care. That delivery of care can include clinicians and healthcare practitioners. It can also have support groups, whether those are tight-linked important others or people serving community-based roles or coaching kind of roles. There's a network of behaviors, and there's a network of linked people whose behaviors affect those of the individuals that we are trying to support with change. So we want to think about behaviors as a systems level of interlocked behaviors within and between people. But that doesn't get us very far. We really want to think about how does behavior change and what can we do to change behavior. If it's not something you're focused on every day, if it's not the core of your work and the core of your mission, we can sometimes have some misconceptions or assumptions that we make about people's behavior and how to change it. I behave, you behave, I see you behave. We have our own theories or common sense models for how behavior change and what we can do to change others' behaviors, right? We do it all the time with our friends, our families, our loved ones. And sometimes those models can be wrong, right? When we measure those models and we look at the application, they can sometimes be wrong. So we want to think about the black box and think about what is inside this box where we don't have a view and what behavior change is in the individual granular components that make up change. I'm going to talk a little bit about those components and a little bit about processes here today, and also maybe why we should care, why we might think about taking a behavior change approach if we're not already to much of the work that we're doing. I was talking to Trina of Kaiser yesterday, and she had a nice line to say that in the work that she does, behavior change is the backbone through all the health applications and all the health services that they offer. And I think that's a really nice way to think about it. It affects everything that we do, and it affects much of what we all care about here today, whether we do that formally or not. we might want to think about it in these terms as well. When we think about digital health in particular and technology for behavior change, there are great opportunities. There is no doubt. Smartphone penetration is up to 5.8 billion in 2020, and those are both Android and iPhone applications, as well as flip phones, which can also serve a role for behavior change. 318,000 mHealth apps on the market, right? Very few of those are completely effective, which is something that we're going to talk about, which is a concern. But there is still a promise of health outcomes, right, by helping people measure, by helping them monitor, and manage all their aspects of health and well-being. But when we look really closely at the data, at rigorous data, right, at randomized controlled trials, we can see that across the board, diabetes, mental health, physical activity, weight loss, smoking cessation, these figures will come from a Nature article that was just published a month or so ago, looking at a bunch of different RCTs across those. And when we analyze things to a rigorous way, we can see that, yes, absolutely, some have positive effects, right? There is no doubt that digital behavior change interventions can work. They can get us to the outcomes that we're looking for. There is no doubt, and some do. However, some suffer from no treatment effect. No effect at all. Nothing seems to be working in those, right? We're not reaching the outcomes that we care about. Some fared no better than controls, so they're no better, they're no worse. We think about things like logging nutrition and apps that help people do that to lose weight. In these studies, they don't tend to work any better than a piece of paper, right? So we're putting in a lot of time, a lot of effort, a lot of money, and when we compare, it's not getting us an added impact for what we are trying to achieve. And then some have a negative effect as well. Certain applications on weight loss again, at the end of trials, people are gaining weight instead of losing weight. So we want to think about why this might be and what we can all do to try to improve those effects. And of course, I think as we all know that many suffer from attrition and dropout, right? Clearly in trials, that's an effect, but in the real world, we know that many people drop out of an app within the first 10 days. 25% of applications are only used once. We have an engagement problem as well. And we want to think about engagement because it is absolutely linked to effectiveness. If we don't have the engagement, we can't deliver the active ingredients to affect the change that we want. And there's no doubt that behavior change is hard. It's excruciatingly hard to change a person's behavior, not just tomorrow, but for the next week, the next month, forever, or at least for years. It's a really hard thing to do. People are different. No two people may respond to the same kind of treatment the same way. They have different things, as we heard a lot about when we think about patient experience, the things people are focused on very much here, building that empathy. The context matters. Things change over time. We're not the same person today that we were 5 years ago. We may have been very easy to lose weight then, but we can't today. You never step in the same river twice, right? We need to think about these long-term effects. And no one has all the answers. No single discipline has all the answers. There is no meta theory for behavior change. The closest thing we might have to real life, right, rather than models and theories, could be chaos theory, but it is not that useful to guide our interventions in our design to do the things that we want them to do. And in design, we have methods. We jump to models, we think about features, we think about the magic that may happen when we build different kinds of behavior change applications and include different features like tracking or social support or text messaging, and we expect, boom, something happens, and ta-da, change has occurred, right? A bit of the underpants gnomes problem. Step 1, find underwear. Step 3, profit. Step 2, we're not really sure what that is. So we need to get a bit more specific and unpack that box, unpack the magic. And when we unpack that box, when we think about that combination of behavioral science and human-centered design, and the process of what constitutes change, the different specific elements, we can break it down into this kind of model. We think about a problem. We think about the intervention, mechanisms of action, behaviors, and outcomes, right? And there's a structure and there's an order to the way we think about those. When we think about the problem, we think here first, right? What is that problem? Who is the affected audience? And who is the at-risk audience for that health problem that we're trying to tackle? We want to know as much as we can about those people and about those contexts, right? Very specific contexts. We want to think immediately from the beginning about the outcomes we're wanting to achieve so that we can plan for them and so that we can design for them right from the beginning. What is that change we want to see in the real world? From there, we want to think about linked target behaviors. Specifically, in behavior change interventions, our goal is to change behaviors. Our outcome is on that behavior, right? New behaviors, different behaviors, frequency, amount, specific to guidelines and health cases. We want to think about what behaviors are reliably linked to those outcomes, what underlying determinants are needed to shift for those behaviors to occur. We just heard a lot about stress, a lot about social factors, about social determinants, resources, the things that underlie people's ability or inability to manage their health, to be productive, to execute behaviors that are both beneficial and wanted within their lives. We need to unpack those mechanisms to a level of detail so that we can target them specifically with the interventions that we design. When we think about interventions, we tend to think about interactions and modules and features and design or content or media. We want to think about an intervention as the specific behavior change techniques that it delivers. Is it goal setting? Is it feedback? Are we using rewards or incentives? Are we using social support? Is that social support emotional? Is it practical? Getting very specific and granular about that so that we can tack it to the mechanisms of action that we want to change. So there's a process here, from the problem to the outcome to the target behaviors to the mechanisms to the intervention and the techniques itself. In order to design that intervention, we first need to deeply understand all those other factors. Spend the time, spend the resources, spend the energy to be very specific and get a full understanding of the picture of the problem. And this gets skipped a lot. We jump to conclusions, we rush through that primary research, we go straight into designs, and we assume that getting an MVP out as fast as possible will be a way to test it and do it. There's certainly value to those effects, but I would not underestimate the time to understand a problem fully and do a proper analysis before we start to design and launch. So we highly recommend doing primary and secondary research to fully understand those behaviors, right? Do that firsthand research with our intended beneficiaries, with stakeholders, with experts. Very common in human-centered design, right? There's one other aspect we like to add from behavioral science is thinking about doing evidence-based literature reviews. Looking at the evidence of what has worked or not worked before for the health problems, for the specific context, for the populations that we're also designing for, and building on that evidence, using it as a baseline for what we do, rather than starting from scratch and rather than shooting in the dark. We want to take that evidence and apply it and implement it throughout the designs that we create. So when we begin, we think about behavior. Why are behaviors as they are? And think very specifically. Ask yourself, who needs to do what, when, where, and how? We want to be able to see that picture, paint that scenario in our minds so that we are certain we know what we're asking, who is going to do what and where, so that we can design our interventions to fit within that population, within that context of where they'll be delivering, where it will be delivered and where they will be interacting with our service. Is it at the office? Is it at the clinic? Is it at home? Is it in the real world? Is it while they're waiting in line at the supermarket? We need to have that picture nice and crisp in our minds so that we can be most effective with what we design. And then we can think more deeply about what specifically needs to change in order for those behaviors to occur. Adam Connor talked yesterday about the COM-B model. It's a model that we use a lot, created by University College London, Susan Mickey. I won't go too much into the model, but just to show you that what Adam talked about in those different factors also tie directly into evidence. When we think about guidelines for designing interventions, we can think about 3 broad categories of what those interventions need to do. We want to help people maximize their capability to regulate their own behavior, right? We want to help them to develop relevant skills. We want to help them develop plans for change. If they need information or education, we need to provide that. But again, I think, as we would all know, education doesn't always provide the quickest path to change or the necessary path to change. We want to build their motivation, changing their beliefs or values, the benefits of changing, their confidence, new habits, positive emotions. We want to reach out and help them find social support where needed, and also thinking about that environment and avoiding social cues, things like places where they may smoke, places where they may drink. Avoid that chocolate cake at 5 p.m. on Thursdays at your office, right? Can we help them change their routines and their environments? And using a model and a framework to go deep and understand each and every one of these specific factors that could be influencing your population, finding that out through research, triangulating that research through literature reviews as well as that primary research, allows us to get down to this level of specificity of the underlying determinants of change. There's a paper and a short booklet that you can download that covers these different mechanisms. This is from an MRC-funded project a few years ago where, again, from the University College London, where data was extracted across different interventions in the research and looked for overlapping patterns of those determinants. What are the most common determinants across different interventions, across populations, across diseases, across contexts? And building a taxonomy to define those, again, so that we have the tools and we have a framework that we can directly address each and every one of the things that actually matter. From there, we can assign the right technique to the right mechanism. If you think of that bundling, that's our goal. We want to understand what those determinants are to affect the target behaviors so that we can drive the right behavior change techniques to those determinants, right? And those techniques we think of as the active ingredients on an atomic level, things that change behavior either on their own or in combination. Most often they're used in combinations and patterns. It becomes a pattern library, but a pattern library from behavioral science rather than from interaction design. We can think of loops that consist of goal setting, action planning, feedback, and potentially rewards or incentives tied to that, right? If we think about that pairing that we see so often in things like trackers and things like SMS messaging relays and things like coaching, right? Set a goal, measure that goal, get some feedback on that goal, close that gap until that gap is met, take on a new goal, right? These kinds of design patterns have an evidence base to them. They snap to specific behaviors. They snap to specific conditions. We can use those as our library, right? And integrate that in to the designs that we create. The art is how we apply it, how we design it into our applications, because they're formless, they're shapeless, and our creativity, our knowledge of design, our knowledge of interaction design is what allows us to apply those techniques so that we are more likely to keep people engaged, we are more likely to get the effects that we're looking for. And those techniques are bundled as a list. It's another toolkit that you can download if you search for it. So they're grouped into 16 categories, from goals and planning, comparisons, feedback. They have a definition and an example. It can take a little bit of practice to work with these. They're slightly dry, but once you start to get the hang of it and incorporate them into your own design work, you can start to really energize the way that you create interaction design patterns, the way that you plan out interventions and how they work over time, the way we think about onboarding, initiation, maintenance, outreach, and re-engagement. We can find the right kinds of techniques that map to our problem and map to our target audience, again, to get our work in the most specific way possible. And when we think about that pattern, the last thing I want to leave you with is not only thinking about that formative research and using tools and frameworks to incorporate those into your design, but also thinking about evaluating all the way through the design process, right? We talk about it a lot. We say that we're doing it. We don't always integrate it along every step of the way. So if we think about this formative research and diagnosis, the design and the strategy and prescription, building what we're building and evaluating it on launch, we want to think about including the people that we're designing for throughout that process, stepping through and testing both engagement, testing the content, testing the effects over time before rolling out and scaling over time. We're at the point where the differentiator and the key differentiator for health applications and behavior change applications and treatments is not going to be on experience or on visual aesthetics. It's going to be on effectiveness. We're at the point where more and more folks are taking on rigorous trials and evaluating those designs for their effects and to see if they work. That is the new landscape of what works and what doesn't work compared to open-range free markets. So we want to really think about evaluating as rigorously as we can, including that into our products, and then starting with a few different frameworks that you can try out with design. I'm over time. That's it. Thank you.